I think the issue of recurrent infection often bothers us, and I will take you through the next 25 minutes on how we need to look at this problem of recurrent infections. I'm sure the problem of recurrent infection needs a clear definition because it may not be infection in the first instance and it may not be recurrent either. And to that extent, let's see how really we go about this problem of recurrent infection. The first thing is that we need to confirm it as infection. First thing that we need to do is to confirm infection, and only after we confirm infection that we need to differentiate between recurrent, relapse and persistent. I think these are not very easy things to do at times, and I will give you what I feel, how I go about it. Once you know it's a recurrent infection, you certainly want to assess the etiology of infection. And at this point of time, you need to evaluate the need for investigation. The point that I want to make is that not every recurrent infection even needs investigations. And at that stage, we need to be very sure how far we need to investigate cause of recurrent infection. Not all causes need even investigations. And I thought that's very important to decide how much to investigate at what stage. For that, of course, you need to consider a relevant laboratory test, and that only gives you probably a good management plan. How do you confirm infection? I think there are many conditions mimicking infection, and one wonders why a well-trained pediatrician on a breastfed baby's loose stool still pursue a search for infection. I think it's criminal, and it's still very much real. Every month I see one child who has had E. coli in stool culture, antibiotic failure, and this child is an exclusively breastfed baby passing some loose stools. I thought we have forgotten our basics too long ago, probably, hopefully after we pass MD, not before. Otherwise we might not have even passed our MD. The point is, it's amazing. How can one just make such a criminal mistake? And I can assure you it's not uncommon. We start right from there and call something infection when there is no infection whatsoever. I know asthma masquerading as pneumonia. I always thought that if I have a clinical diagnosis of asthma, I should not ask for a chest x-ray. If I ask for a chest x-ray, the radiologist obliges by calling it pneumonitis. To me, pneumonia is inflammation, and inflammation of inflammation is pneumonitis. I don't know from where this term has come in at all, and you just want to satisfy your justification of an antibiotic. And I feel that therefore it's best that you don't ask for a chest x-ray if you don't anticipate a pneumonia. Otherwise you will find a pneumonia. I know a good radiologist who says, what do you want me to give you on x-ray? A collapse, consolidation or a cavity? And all that in a normal child. So I think radiologists can do wonders, and we need to be aware of that. I'm sure all of us have seen sickle cell disease, almost mistaken for osteomyelitis. This is no infection whatsoever. You have a parotitis. Once in a while, if it comes for the first time, I call it mumps. If it happens second time, I call it rare recurrence of mumps. If it happens every month, I call it immune-mediated parotitis of no clear understanding why it happens. It's no infection at all. And even if it's parotitis, so what? It's mostly viral. Why should you give an antibiotic whatsoever? And I'm sure we have seen collagen vascular disorders coming with infection. How do you diagnose infection then? I think there is no hurry to diagnose infection. There is a hurry to be sure that the patient will not die of whatever he has, infection or otherwise. If the patient is stable, I think there is no reason to hurry through. I'm sure acute infection is acute onset of high fever, but all those rest of the things have to evolve over time. There are many diseases which evolve, and then only you can take up to their diagnosis. Classical examples of collagen vascular disorders, which take few weeks to evolve to even label a diagnosis. Where is the hurry? And I feel in the first 2-3 days, every fever is of unknown origin. You even don't know whether it's an infection or not, and there should be no hurry at all. These are not the terms which are easy to differentiate clinically. Relapse is often once. I know people who have failed again and again, relapsing failure, but that's not common in clinical medicine. Relapse is often only once, and if it happens second time, it's a failure of a medical professional and not the failure of a disease or a drug. Usually occurs within a short period, and you always know the problem of compliance, drug resistance, etc. I think the issue comes up when there is a persistent infection but a recurrent manifestation. Every one of us has learned that tuberculosis comes as fever off and on. Therefore, there is an off also and there is an on also. You can call off and on as recurrent fever if you like, and still the disease is persistent. So disease may be persistent, symptoms may be recurrent, and you are likely to call it as a recurrent infection, and you need to be very sure to pick up that in between apparently a symptomatic period, whether this was really a normal period whatsoever. These children are always not normal. But after all, they have less fever now or no fever and appears to be a recurrent problem. Whereas we call recurrent really when it happens too often. I'm sure if it happens second time, it's a bad luck. If it happened third time, it's bad luck of a patient that he's with you or me. He must have been with somebody else. And therefore, I think once we know that it's a recurrent infection, the next thing is, of course, whether it's a bacterial infection. I strongly believe that in an office practice, it's very easy to differentiate bacterial from viral. You don't need a laboratory. If you complain to say that you don't have a reliable laboratory, you don't have to rely on a laboratory. Why do you want to have a reliable laboratory? And if you don't have a virology laboratory in the country, you don't need that either. That's all required for a research. And we haven't searched as yet. Where is research for us? So I think let's be factual and say we don't need a laboratory most of the time. If you have a laboratory, you might be in trouble. So ask for a laboratory help only if required, not otherwise. And I think how do you diagnose an acute onset, mild to moderate fever, worsens over the next few days. You have a poor response to antipyretics. The patient keeps on remaining sick. Even during interfebrile period, very soon he localizes infection. Bacterial infection is localized, viral is generalized. And a viral respiratory infection, your eyes are red, the nose is running, the throat is congested, you are coughing badly. In a bacterial infection, tonsillitis have no chest signs and a pneumonia has no congested throat. I'm sure all of us during our residency post always wrote to say throat mildly congested. Mildly means not also congested, and crepitations occasional. I always ask my resident which was this occasion when you heard the crepitation. Yeah. So I am sure that is not what a bacterial infection means. It's not occasional. It's right there all the time. Of course, if you have a purulent discharge, you are lucky. Again, a yellowish discharge may not mean a bacterial infection. It could be viral as well. And if you have a greenish, foul smelling, even a grandmother knows it's a bacterial infection. So where are we then? Well, it does respond temporarily to antibiotics, but the best part is even viral infections respond to antibiotics because they also get better. So response to antibiotic is a poor way to say it was a bacterial infection. The point is, if you have a bacterial infection which is recurrent, then you have to search the background cause. No one gets second episode of bacterial infection unless there's something wrong with you. It could be wrong something with the host or with a drug or with a compliance or with a doctor, whatever, but there has to be a background cause. And I think the recurrent bacterial infection, therefore always search for a background cause. What's the moral of the story? If you were to prescribe an antibiotic within a short period of time, again, for a similar infection, and you called it, oh, you're unlucky, you have another tonsillitis coming in a month's time, or another pneumonia coming up. I think there has to be a background cause. While you may treat second time with another antibiotic, you have to investigate this child for a probable cause. And obviously, one of the three factors may be responsible. We know that it's the combination of these three factors that present as a disease. You have a problem with an organism, an environment, or a host. For example, we know that if the organism is really partially drug resistant, it could get better partially and then come back again, and you might call it as a recurrent infection. In my impression, it is not a very common thing to happen in a common office practice. So drug resistance does not exist as far as a routine common office practice is concerned. Well, sometimes there are some organisms which can be difficult to get rid of, and one of the examples is an adherent E. coli in a urinary tract. Where E. coli is quite drug sensitive to whatever antibiotic you are using, but you can't easily displace them. They are very adherent and almost like a parasite, like a giardia, not getting out after even a good metronidazole therapy. I think these are occasional situations, and I don't think we need to worry about it at all. So let's believe that in a recurrent bacterial infection, the organism is not at fault and the drug is not at fault. Sometimes the environment is at fault, and I'm sure this is especially true with a recurrent diarrhea. If you have a diarrheal baby coming recurrently with bacterial infection who is bottle fed, don't waste time, throw the bottle and you will have no recurrence. All of us know that very well. But most of us are addicted to the bottle. Difficult to throw the bottle. And therefore, even if we know, we don't. And I think that's the reason why these diarrheas continue. Therefore, largely, when it's a recurrent bacterial infection, the host is responsible. And let's look at the host, what's happening to the host. Well, host has three kinds of problems, obviously, an anatomical, and I was listening to the case presentation, you had a congenital malformation, and that could come as a recurrent infection. I also saw some of you arguing whether it was a shift or a collapse or an neurogenesis or hypogenesis or whatever. Yes, so congenital malformation is one anatomical reason. I'm sure you have an adenoids there, you have a persistent focus of tonsils, sinusitis. I'm sure Dr. Jagdish talked of rhinosinusitis yesterday, day before morning, and we know that sinusitis is very underdiagnosed. We need to be very sure this could be causes of recurrent bacterial infections. Every time you give an antibiotic for 5 or 7 days, it's interesting to know that if you give an antibiotic for 10 days, prescribed logically, nobody takes for 10 days. A study in 80s in Britain, where the doctors as patients were evaluated, and 80% of the doctors as patients did not complete even 5 days of antibiotic. Why? Because they are busy, as if the patients have no other business but to take medicine. So I think and that's why the discussion the other day, whether you can give amoxicillin once a day, I hope it could be once a week and so on, then only we have a compliance. The point is that it is not uncommon that a recurrent bacterial infection may be simply because some foci of infection remain uncontrolled. You need a right type of an antibiotic for a right length of time. We all are aware of a UTI with an obstructive uropathy. Meningitis due to some such anatomical malformations, and these are all rare. If they are there, they are easy to make out. What you need to really pick up is adenoids, and I'm sure today the most common infection in office practice are upper respiratory infection, and most common cause of recurrent infection is also upper respiratory infection, and the adenoid sinusitis, I think, is a very, very common thing. You have a comorbidity in terms of atopy, you have a combination of atopy and infection, and I think all that is causing the problems which are in the background for a recurrence of infection. They are not difficult to make out because I think some of them are staring at you straight off on your clinical examination. Child has an adenoid face, each child has an open mouth, child is snoring, and you know that he has a problem that needs to be tackled beyond giving an antibiotic. Well, at times you have a functional problem, not anatomical, and we know a GERD doing that, swallowing dysfunctions in a neurologically impaired patient in particular. You have a vesico-irritable reflux there, and you have further rare conditions like a cystic fibrosis, etc., which makes a functional abnormality, like say a ciliary dyskinesia, and because of the functional abnormality you keep on getting a recurrent infection. Again, not very difficult to make out unless you really fail to even search for it, and you know that this is thing. I was amazed when I was asking some postgraduates who had recently passed when they looked last for an adenoid, and they said, what is adenoid? I know pediatric pulmonologists like Mahesh Babu says, never ask for a chest x-ray for adenoids. Well, adenoids are looking at you. Why do you want to know it radiologically? And even if they are there, what the hell are you going to do after a chest x-ray? I think these are all difficult. After all, a pediatric pulmonologist can know many things what a radiologist cannot tell you. But you and me are not pulmonary specialists. Now, the congenital malformations, again, this child was getting recurrent infection there, and sure enough, he has some kind of a malformation there, staying with it all the time, and you know that if you have a recurrent infection in the same lobe, then you certainly look at that. And this child has got an aspiration pneumonia there in a small infant, and we are all aware that if you have such recurrent infection, then you have down the line some functional cause. And then, of course, immunological cause. Immunology is difficult to understand, and one need not understand because it is so rare. And therefore, whatever you don't understand, send it to some expert. Be sure he also doesn't understand, but he has to portray that he does understand. Knowing that you don't understand, he makes you feel he understands. And I don't think any one of us understands. So let's not worry a great deal about it, but it's nice to talk theory from this podium and say, oh, T cell defect, B cell defect. I said, don't you know your ABCD? Where are you going from T to B? You have obviously an opportunistic infection. Well, they do exist. I'm sure all of us seen. But to think about immunological problems is a rarity. And I don't think it's common at all in clinical practice. They are not difficult to make out. You have all kinds of infections coming up early in a well breastfed baby, well looked after. Why is she getting infection at all? Must be something wrong with the immunological system. B cell defect obviously comes a little later in infancy because you have a maternally transmitted antibodies which protect for first few months, and thereafter certainly those infections can come up. And then of course there's many other types of defects, and you have an acquired defect, HIV. But what we don't realize is the commonest immunological abnormalities and abnormal immunological system function are not these B cell, T cell, etc., but simply a malnutrition. Malnutrition is a very potent immunodeficient state, and I think that we see very, very commonly. And another not uncommon immunologically suppressed patient is any chronic organ dysfunction. I'm sure a chronic lung disease, a chronic cardiac failure, a chronic hepatic failure, a chronic renal failure, all of them are immunologically compromised, and they are not seen as immunologically compromised children, but yes, they are all prone to infection rather easily, and you need to look at beyond what we understand as immunology. The immunologists don't take care greatly of all this, and we only look at these commonly as most immunological problem. And I'm sure this is a typical IgA deficiency child who keeps on getting recurrent infection. How do you suspect immune defect? It's rather simple. You have a multiple infections, multiple systems involved, and you have a progressive deterioration. You have an unusual organism which is in a community, and I think that might give you an idea that there's something wrong with his immune system. You have an atypical progression. He's not progressing the way normally you would expect him to. He has a poor response, and I think in which case only you might have to go in for some more studies. But you have an easy way. BCG is almost universally given, and it's a good T cell function test. If a BCG is well taken up, you know his T cell is good enough. And I think that's a good idea. Look at the BCG scar. If there's a good BCG take-up, well, scar is not necessary. If he has a T cell deficiency, he would flare up with that live bacterium there in a BCG, and he would have a disseminated BCG infection. And I think therefore a BCG is a good T cell function. I don't need a laboratory at all. This is what we already said. Some of these immunological deficiencies may go on very, very slowly, and it's quite amazing to know that a large number of us may be mildly IgA deficient. IgA deficiency is pretty common, and many of them may get over as the age advances, and to that extent the other immune functions take over the deficit of IgA. But if you have an IgA 0, then of course you are doomed. By the time you are in a second decade, generally repeated respiratory infections can take a toll of a chronic respiratory failure. This is then fine that how do you manage a recurrent bacterial infections if you have in an environment of any drug resistance, etc. If you have an anatomical defect, you have a surgical treatment. If you have a functional abnormalities, then beyond just the medical treatment. But the message I want to give you is that if you were to write an antibiotic within a short time for a same infection again, I think at that time only you need to be sure that you're not missing some fact behind this kind of a recurrent bacterial infection. Well, there are recurrent bacterial infections of unknown cause. And this is all that we know so far. But we do see skin and soft tissue infection. We do see children who come with a repeated skin and soft tissue infection. It could be unhygienic situation. It could be environmental related. But I'm sure that some of them have a mild polymorphic function defects which probably get over as the time goes, but they do not. And I'm sure many of you might have seen children who come with an abscesses one after another requiring incision drainage. They don't seem to have any great other immunological abnormalities, and such unknown issues do exist in clinical practice. this afternoon talking with Dr. Jacob John about a varicella, natural varicella recurring sometimes, even within a year. He happened to mention to me that there are some children who have a specific defect against a specific organism. I suppose this is a hypothesis that you have an immune deficiency against varicella only. I don't know what it is. And he said that yes, there are such children who have a specific immune defect that they can't fight a particular bacterium or a virus, and they keep on bothering them again and again. But in general, they're all immunocompetent. I don't know whether some of these really indicate that side. Intestinal parasitic infections, we all know that parasites are as it should be, not go away from the host anytime, sometimes displacing the host if the host starts troubling. And I'm sure some of you have stayed in the hostel as a parasite or allowed a parasite to stay with you. And back home at the Grand Medical, we had more parasites than the students in the hostels. And the students had to tolerate that. And very soon the warden didn't know who was a student and who was a parasite. So that close bond, close relation on one faith, that you don't disturb me, I don't disturb you. But you start disturbing me, then I disturb you too. Parasites are literally that, and they will continue to have a recurrent infections of unknown origin. You have occasionally a UTI recurrent which has no anatomical or even functional defect, and you don't know why he is recurring. That's certainly not common, and every UTI you have to find an anatomical or a functional defect. And I do know occasionally typhoid fever which just relapses, and we had a doctor's child who relapsed third and fourth time in spite of a compliant intravenous antibiotic therapy for good 2 weeks, etc. And sometimes it certainly means that whatever you use a standard therapy may not be adequate for a given child, and then he keeps on relapsing recurrently. We don't know whether there are such immune defects. The point that I want to make is that sometimes these infections recur for no rhyme or reason, no cause known. And that's the time that you are looking for any explanation or anything that happens. And this occasionally, not commonly, happens with a recurrent bacterial infection. But then there are many recurrent non-bacterial infections, and we don't know why they recur. The commonest is a viral infection. I've already said that viral infection is easy to diagnose, starts with a high fever. By day 3, day 4, the whole thing is getting better. You give an antipyretic, the fellow runs within half an hour as if he had no fever at all. And he's not sick, he has a disseminated infection. I think viral infections are very strong and reasonably correct. Viral infection as a diagnosis. And such infections keep on recurring. I'm sure all that we do is to tell the parent, this happens normally. If it happens in winter, I said the weather is so cold. If it happens in rainy season, of course you get recurrent viral infection. And if it's bad summer, then why not? The fellow doesn't know that means you have said all the year you will keep on getting infection. What can I do? The weather change. And the weather change is nice. More often the weather changes, better it is for you and me, because then you can say weather changes. But you don't change. You keep on saying the same thing. But I think parents expect a control of recurrence. I'm sure all of us are continuously bogged down by patients coming again and again say, how often? It's nice to tell those who have been in United States once to say, oh, there you see, not 6 but 8 times a year. Oh, so if the white man also gets his child recurrently, why not the brown and the black? That's quite a relief for many, which means you're not backward in this country medically. But you need to have an answer to that. Surely then what's the answer? You give another antibiotic. Oh, that's not an answer at all. You do a Mantoux test. Oh, you have committed a crime. Here is his nose flowing and you are doing a Mantoux test. What are you looking at? Tuberculous rhinitis? What's wrong with you? And therefore, I think then you do all such things and finally dump him on some treatment. He hopes that a 6-month treatment will keep his problems away. By then he keeps you away. And I think that's how the whole thing. So you have the recurrent viral infection to which you have no answer at all. Every one of them gets well, but I recall diarrhea. Okay, when ORS came in, we said you keep on going to the loo, doesn't matter. You will not die of dehydration, we have an ORS. The fellow says, your ORS, I don't care. I must stop my going to the loo frequently. His demands are different, your treatment is quite different. I think here is a viral infection. The textbooks will say, you reassure. You are not sure yourself. What reassure? I think we need some answer. I don't know the answer at all. Okay. And as you get senior, you see less of those. Okay, because by the time they think of coming for a second opinion, the disease has gone. That's always nice. And you know, second opinion is the easiest opinion because you know many wrong things that the first one has done, and all that you have to be careful is not to do the same mistake again. I think this is really a problem, and you have no solutions. Every child after 1 year keeps on getting it. Every year you tell him, I hope this is the last year that he gets in. When he joins the school, you say first year in the school. And what about first year before the school? Yes, of course, first year before the school, first year after the school, first year during the school. I think we all grow out of that. We have no answer medically. We only know that this is benign. Oh, it could be benign, okay, but I need an answer to that. I need a solution to it. Today I have no solution to it at all, and I don't know what the pride is. And you will hear what the pride is, and you can be proud of it or otherwise, but I don't know that. So we need something like that. You have a recurrent malaria. Mosquitoes are there, not recurrent, persistent, continuous. And you still get a recurrent malaria. Not everyone gets it. Few get it. So every time I have a child coming second time with malaria, I said, well, we just give a suppressive treatment because we don't want to cure you. You're going to stay with all these friends of yours, and you have to be friendly and nice to them. Generally, if you are nice, they are nice to you. And if you find a child getting recurrent malaria, you have no answer. You don't know why he's getting. Most of the parents ask you to say, well, the mosquitoes are biting everyone, but only he is getting repeated malaria. We don't know the cause. And I'm sure then we go on either giving chloroquine every week, you use primaquine. I'm sure that there is no easy answer. One who wants to recur will recur, and in spite of all what you do, he will recur simply because you don't know why he's recurring. And if you don't know why it's recurring, what can you do? And I think these are real problems of recurrent infection as far as I see. Are they really transient immune deficiency? Yes, there are some transient. There are many transient things. Transient hyperammonemia of a newborn. God knows why transient and why troublesome. There are several such transient things. And you have a subclass IgG deficiency, recurrent infection in young children improving over years. You have a partial IgA deficiency, very common in community. Recurrent respiratory or a GI infection get better over time. And thereafter we all remain normal. We don't know what this transient immune deficiency is, that we have no easy measure, we have no easy answer to that either. You have many others like a neutrophil function defects which present even in a little older children with recurrent soft tissue skin infection. And of course you have a nutrition-induced suppression and a recurrent infection. How do you really manage these recurrent infection of unknown cause? Most of them are self-limiting, and we know that they get better over time. I'm sure if you get senior, then you start seeing more doctors' children. Okay, they never send you a patient, but they bring their own child to you. Well, that's a compliment to you because they believe in you, and they don't mind their patient going anywhere else. So, and I think you know that every doctor worries a great deal when the fever recurs even a bit once more. And when we find a patient coming to us, say, oh, don't worry. I remember a surgeon who was operating on a patient, and patient said, Doctor, I'm quite worried. He said, why are you worried? He said, no, doctor, this is my first surgery. Doctor said, this is also my first surgery. I'm not worried. So, if I am not worried about my first surgery, why are you worried about your first surgery? So, I suppose we all tell our patients, oh, don't worry. Okay. And when your own child, much before he starts fever, you're worrying. So, I suppose there could be an answer in clinical medicine. As of now, I don't know the answer. And I keep on reassuring. And many times I get a patient for second opinion, not because I understand it better, because I'm supposed to say the same thing what the junior said, and therefore the patient says, junior or senior, they're all equal. A control of recurrence is not feasible as per the standard thing. And a common thing that my parents ask me is that, I think, doctor, his immunity is low, and he has a low resistance. I don't know how the resistance is measured. I learnt in physics about resistance. I don't know whether that's the resistance you're talking about. What is immunity? I don't know. And then you say, okay, I'll give you some immune boosters. I don't know what are immune boosters at all. In my practice, I have never used them because I don't know what they are. But surely they are there. They are there in the market. In the market, you have also drugs which can improve brain function. I didn't know that. My mother didn't know it either. That's where I am now. And therefore, I think I don't know what these immune boosters are. And that's where I think I leave this platform to say, are there any immune boosters? I'm sure half of you must have used some of them. And most of you know they are not worth using. That's the beauty of it. Most of us believe in one thing and do something else. Industry knows it very well. So I think let's hear now, are there any immune boosters at all? Therefore, I'll just sum up to say recurrent infection is really a problem when you don't know the cause. Recurrent bacterial infection is no big deal. You know the cause. Cause may be apparent. You have to search for it. It may be treatable. It may not be treatable. But you have an answer. You have a direction. When you have an unknown such recurrent infection, you have no cause known. You have no solution known. You keep on reassuring. And I think that's where I leave this platform. And let's see whether there's any immune booster whatsoever. Thank you very much, Chair.